The next topic will be presented by Dr. Androulakis. He's online. He's going to present the topic, Emerging Concepts on Fibrosis in Non-Ischemic Cardiomyopathy. So Dr. Androulakis, a consultant in St. George's University in King's College, London.
Hi there, good evening. Can you hear me?
Yes. Hello.
Can you see my slides already?
Yeah.
I've started sharing.
Right. Everything is fine.
Fantastic. Thank you so much. My name is Androulakis. I'm a consultant cardiologist at King's College Hospital and a senior lecturer at King's College London and St. George's University. I used to work at St. George's. And obviously we're closely collaborating still in the university. Many thanks for the kind invitation I wish I would be there with you and your beautiful city, but unfortunately I wasn't able to. This is a great topic and something, in my opinion, that has got various implications in pathologies and clinical practice. Phenotyping in cardiomyopathy, as you know, requires a holistic approach, including clinical assessment, family history, screening, various investigations, and so on. However, myocardial fibrosis, as you know, has emerged as an integral part of phenotyping cardiomyopathy, particularly the last 15 years, without the need of invasive myocardial biopsy, but with the use of cardiac MRI for morphology, function, but also scar assessment. As you know, this assessment has got extremely important implications for all cardiomyopathy types, both for diagnostic but also for prognostic purposes. We shouldn't forget that CMR has developed obviously quite a lot recently, and nowadays we utilize both we not only utilize contrast but also techniques for tissue characterization such as ATT1, ATT2, extracellular volume analysis, and so on, in conjunction with fibrosis assessment. And obviously, not only that, as you know, inherited cardiomyopathy can many times overlap with athletic adaptation. And I would also like to briefly touch upon that topic as well, which I think is extremely relevant. Outside this is evaluating the role of fibrosis by means of qualitative assessment. We have started going a bit deeper already in terms of more advanced techniques that we've been using in research and has shown great potential contributing to what we call precision medicine, like the emerging role of precision medicine in genetic cardiomyopathy. First, let's talk about the role of fibrosis in HCM, and I heard very carefully the previous talk about the HCM with the great experts that you have. Basically, our role is to try to investigate the hallmark of the disease, which is, as you know, myocardial disarray and interstitial fibrosis, which then becomes diffuse or replacement fibrosis. And we will see some examples mainly in patients assessed with cardiac MRI. And obviously, as you know, although there are patients that can appear similarly on echo as these ones, with the use of MRI, we can easily distinguish, for instance, the unusual dense fibrosis pattern and basically pretty much suspect the diagnosis of HCM versus LVH secondary to hypertension, which is the first patient. Relevant to this, I would like to mention very briefly there's various information that we can get and we need to combine in order to make the correct diagnosis from phenocopies such as cardiac amyloid, Fabry's, aortic stenosis, and so on. And this would be native T1 mapping or ECV, obviously apart from the information that we get from fibrosis. Very careful holistic assessment, advanced imaging. We can also use in complex cases, but also young individuals that not only have hypertrophic cardiomyopathy, but also other conditions, such as this case of mine, basically an endurance veteran athlete with apical HCM, but also at the same time cardiac involvement due to AL amyloidosis, plasma cell neoplasm. And therefore you can imagine that's really important, not only for diagnostic purposes, but also for prognosis. I mentioned before, a classic differential problem is athletic adaptation, and we have obviously nowadays various advanced imaging techniques that we can use both in practice but also in research, and enable us to identify features pointing towards one direction or another. And you can easily imagine the consequences of basically labeling a professional athlete with a false diagnosis for his career and so on. Growing evidence, however, at the same time has provided insight around the use of artificial intelligence in the improvement of risk stratification models. And without going into much detail, for instance, this study that showed LG radiomics are associated with certain risk in hypertrophic cardiomyopathy, and provide incremental risk stratification value beyond current ESC or AHA risk models. I'm going to discuss now the important topic of other cardiomyopathies, and I've deliberately put together what we call dilated cardiomyopathy / arrhythmogenic cardiomyopathy spectrum. As you know, there's growing understanding that there is some overlap between the two. And not only that, we're even moving towards gene-specific diagnosis as opposed to this broader spectrum of conditions. And let's start obviously with the basics. As you know, there are different types of fibrosis in different locations and different patterns, and accordingly can guide us to a specific diagnosis or another. Going a bit deeper into pathophysiology and natural history, this study we aim to characterize the phenotype, clinical outcomes, and basically disease progression in patients with early cardiomyopathy with a median follow-up of 8 years. And we divided the large cohort into basically 3 categories: isolated LV dilatation, non-dilated LV cardiomyopathy, and early DCM, early dilated cardiomyopathy. And very briefly, we noted fibrosis mass and location was different in different groups, but also we noted how this progressed to basically a stage of more overt dilated cardiomyopathy. And moving away from early forms, this is an observational study of a large cohort with DCM, so basically dilated cardiomyopathy with mid-range and ejection fraction during a long follow-up using multi-parametric CMR analysis with feature tracking, global longitudinal strain, and fibrosis analysis. And we found that LV global longitudinal strain stratifies risk of progression to heart failure, while LGE stratifies harder endpoints such as sudden cardiac death risk. Another performance, this is a large multi-center study including 1,700 patients with non-ischemic cardiomyopathy from centers in the UK and an external validation. Basically, we quantified myocardial fibrosis, but also what we call gray zone fibrosis, which is basically the area around the fibrosis, testing basically the assumption that this area is probably more active electrically and may give rise to arrhythmias, as opposed to the dead scarring tissue in the core of the fibrosis. And the higher total fibrosis mass and gray zone incorporation added more value to the prediction model. In contrast, as you can see here, left ejection fraction of below 35%, which we currently use in our guidelines, was a poor predictor of the primary endpoint. Let's move on to something a bit more, but we're still in dilated cardiomyopathy, a very recent publication of a prospect report. We aim to basically for a greater precision in arrhythmic risk stratification of patients with non-ischemic cardiomyopathy. And basically we try to evaluate whether fibrosis entropy, which is a measure of scar tissue heterogeneity, again derived from CMR analysis, has incremental utility to fibrosis presence for specifically arrhythmic risk. And without going into much detail, deeper phenotypic characterization of the scar using fibrosis entropy offered incremental utility to the ejection fraction, but also to the fibrosis presence and fibrosis quantification for specifically the arrhythmic risk stratification. Now, a few words about arrhythmogenic cardiomyopathy. As you know, we have the right-sided disease, as you can see here, with fibrosis in the right ventricle. We have the left-sided arrhythmogenic cardiomyopathy, here a few examples. And for instance, ventricular fibrosis, but also on the top of that, you see here from the CMR non-contrast and post-contrast ECV analysis, there was active diffuse enhancement, but at the same time active myocardial inflammation, so myocarditis. We sent this patient for genetic testing, and he was found to have a nonsense variant causing haploinsufficiency in the DSP. And basically what we know nowadays, that myocarditis is basically, many times we can see that phenomenon of myocarditis as bouts basically of inflammation. However, in principle, there are specific genes correlating with arrhythmogenic phenotypes that can cause that. And this is basically studied from the same group of researchers in our institution, showing basically the genetic architecture of DCM/ACM genes. And 80% of the patients with acute myocarditis in a large cohort of 1,400 participants shown to have these genes, and more frequently genes in DSP truncated variants and other genes that were relevant in this cohort. And I'm showing this just to highlight that nowadays we have moved towards specific gene signatures, which basically define the extent and location of fibrosis, but also contribute to specific gene cardiomyopathy risk profiles, without always this being directly related to the amount of fibrosis. There are specific genes that this is not the case. And the last topic of athletes, I think it's quite relevant and has gained global recognition. However, in my opinion, it poses even higher challenges to the clinician, is the topic of athletes. Unfortunately, in athletes, we don't have that well-validated large cohorts and cohorts with pathologists and so on. So data are not as well-validated. This is from a previous meta-analysis of mine, basically showing that athletes, and we can discuss about this, have more prevalent fibrosis versus controls. However, had some more favorable features, such as lower native T1 mapping. This is a follow-up meta-analysis comprising 21 studies involving 1,600 endurance athletes. Myocardial fibrosis was found in 378 of them. Native T1 values were, as before, significantly lower, and in ECV was similar. We documented in this one various types and locations of fibrosis, both in different age groups, but also such as obviously young and veteran athletes, but also male in females. And basically what we think is the development of myocardial fibrosis in athletes is probably a multifactorial process comprising genetics, hormones, exercise dose, and so on. What can it be hidden in terms of fibrosis in athletes? We think some sort of myocardial inflammation of various causes, what we call myocarditis. And this is a relatively large cohort of athletes presented with acute myocarditis. As you can see here is the distribution of LG at baseline. And although it's more prominent in ferrolateral walls, basically it's pretty much everywhere. However, at follow-up, as you can see, there's significant improvement both in athletes and non-athletes. And there seems to be regression of patterns in the follow-up scan. Interestingly, the septal and anterior segments, basically, we found that they're not coming back to normal that often. And these were exactly the patients that are basically related with more adverse events. And I've been trying to actually study the fibrosis in athletes, and this is a cohort, this is just for young individuals with no known cardiac conditions, and I'm highlighting this. These are proper athletes, professional ones. We characterize the pattern, location, and extent of fibrosis, divided it into minor and major. And we've been studying this with various other parameters such as ECG, arrhythmias, CPET, and so on. And in follow-up, we did notice that some of them, the ones that had major fibrosis, basically, had basically more adverse events. And going a bit deeper, we're trying to basically identify a machine learning-based risk prediction model with which basically we could predict the presence of clinically significant fibrosis, meaning the fibrosis that can lead to adverse events by means of baseline assessments such as ECG, arrhythmias, CPET, and echocardiogram. And we identified a classifier with which we could predict that significant fibrosis in 90% of the cases without even having to do the MRI, which I think is particularly interesting. And instead of a summary, to conclude, and as this title of presentation mentioned, emerging concept of fibrosis, as you realized, fibrosis is not just another pathology of the heart. It's a complex phenomenon that in order to understand, I think we need to go a bit deeper in terms of phenotyping, obviously utilizing other things such as proteomics, genomics, metabolomics, and so on, but also with the use of artificial intelligence, which will enable us to utilize a huge number of data in the aim of creating and validating diagnostic and prognostic models, which hopefully clinicians will be using at some point in practice soon. Thank you so much for your attention.
Thank you, Dr. Androulakis. We're a bit late. We only have time for one question. Is there a question from the audience? Okay, thank you so much.
My pleasure. Thank you so much for the invitation.
Okay.
Thank you.
Now we go on